For decades, we were promised that modern medicine would catch disease before it killed us. Early detection was supposed to be the revolution. Screenings, scans, annual checkups. The system would find problems while they were still fixable. In 2019, the World Health Organization declared that 75% of the world's dementia cases go completely undiagnosed. Brain cancer carries a 5-year survival rate of just 4.7%, not because we lack treatment, but because we find it too late. Now, in 2026, artificial intelligence is reading brain scans and finding tumors, predicting dementia, and identifying disease in patients who feel perfectly healthy. The technology works, and it raises a question medicine never expected to face. What do you tell someone whose scan reveals a future they cannot yet feel? The numbers are staggering. Someone develops dementia every 3 seconds worldwide. The global cost exceeds $1.3 trillion annually and is projected to hit $2.8 trillion by 2030. Brain tumors account for only 2% of all cancers, but carry a disproportionately lethal 34% 5-year survival rate overall. According to Johns Hopkins Medicine, traditional liquid biopsy approaches detected brain cancer less than 10% of the time. Meanwhile, Alzheimer's-related brain changes begin 10 to 20 years before any symptoms appear. For 2 decades, disease silently destroys tissue while patients pass every standard medical test. The Alzheimer's Association estimates that early detection of mild cognitive impairment alone could save over $7.9 trillion in health and care costs. The UK Alzheimer's Society projects that catching disease earlier could reduce severe dementia-related mortality by 30,000 people annually. Today, we are going to look at how artificial intelligence finally cracked what traditional medicine consistently failed to solve, and why that breakthrough creates problems nobody anticipated. Here is the fundamental problem. The information was always there. Doctors just could not see it. Researchers call this the scan paradox. Every year, millions of brain MRI scans are performed across the United States. Radiologists examine them for the specific reason the scan was ordered: a headache, a fall, routine follow-up. They find what they are looking for, and they miss everything else. Dr. Benjamin Can at Mass General Brigham put it bluntly in a February 2026 interview with Medical News Today. He said that typically these scans are analyzed by humans for a particular reason, but this only scratches the surface of the story that these scans might tell us about our patients. The data proving you have early-stage dementia might already exist in a scan you had 3 years ago. The signature of a tumor might be sitting in hospital archives. The pattern indicating your brain is aging faster than your body has been recorded, filed, and forgotten. Dr. Wallavan Sivakumar, a board-certified neurosurgeon at Providence Little Company of Mary, explained the limitation. Advanced models like this can identify subtle, distributed signals, like early patterns of atrophy or microstructural changes seen in tumors that are either not visible to the human eye or for which we do not have standardized reports. The scan held the answer. We simply could not read it. Until now. This brings us to the most significant development in neurological diagnostics in a generation. In February 2026, researchers at Mass General Brigham published a study in Nature Neuroscience introducing BrainIAC, the Brain Imaging Adaptive Core. This AI foundation model was trained on nearly 49,000 brain MRI scans using a technique called self-supervised learning. It learned how the brain is structured without being told what to look for. The results stunned the medical community. BrainIAC can identify brain age, how old your brain appears compared to your chronological age. It can predict dementia risk in patients showing no symptoms. It can detect brain tumor mutations. It can forecast brain cancer survival rates. All from a single routine MRI. Dr. Can emphasized the practical implications. With AI and advanced computational imaging techniques, we are able to unlock much more information from these scans than ever before, which may lead to potent, clinically useful ways to track a variety of acute and chronic conditions, from stroke to cancer to dementia, and to predict future risks for patients. The model outperformed task-specific AI systems, especially when limited training data was available. In scenarios where only 10% of training data was accessible, BrainIAC still delivered robust results. Dr. Khan noted that this opens the door to institutions adapting BrainIAC for their own uses without needing thousands of labeled scans. That had been a barrier that previously made AI deployment impractical for smaller hospitals. Mass General Brigham released BrainIAC as open-source software for research purposes. Any hospital, any researcher, any practitioner can access it. The tool that reads the secrets in your brain scan is now freely available to the world. But BrainIAC is not alone. A parallel revolution is unfolding across multiple detection methods, and together, they are rewriting what healthy actually means. The AI diagnostic ecosystem has expanded with remarkable speed across every possible detection method. At Johns Hopkins Kimmel Cancer Center, Dr. Dimitrios Mathios and Dr. Victor Velculescu developed an AI-powered liquid biopsy that detects brain cancer from a simple blood draw with approximately 75% accuracy. Previous methods caught brain tumors less than 10% of the time. Their simulation showed that screening 10 million headache patients presenting to emergency rooms annually would identify roughly 1,700 additional brain cancer cases that current approaches miss. The technology has been licensed to Delphi Diagnostics for commercialization. At NYU Langone and Northwestern University, researchers achieved 98% accuracy in detecting intracranial tumors using quantum-modified carbon nanotubes analyzing blood plasma samples. The system distinguishes between glioma, meningioma, pituitary adenoma, and schwannoma, all from a single tube of blood. Queen Mary, University of London, demonstrated AI that predicts dementia onset up to 9 years before clinical diagnosis with over 80% accuracy. Professor Charles Marshall said, "Predicting who is going to get dementia in the future will be vital for developing treatments that can prevent the irreversible loss of brain cells." At the University of Cambridge, Professor Zoe Cortzi's team validated a machine learning algorithm across 1,900 patients in 3 countries. Her most striking claim was, "We've even been able to identify some patients who were not yet showing any symptoms, but went on to develop Alzheimer's. In time, we hope to be able to identify patients as early as 5 to 10 years before they show symptoms as part of a health check." At Duke University, Dr. Sharon Fekrat and Dr. Dilraj Grewal trained AI on retinal scans, which are images of the eye, to detect Alzheimer's-associated changes that are invisible to human examination. The retina is the only part of the central nervous system visible without surgery. Dr. Fekrat noted that retinal imaging is non-invasive, cost-effective, and widely available, positioning it as a potential population-level screening tool. The technology works. The detection windows are measured in years, sometimes nearly a decade. The question is no longer whether AI can find hidden brain disease. The question is what we do when it does. But the most troubling aspect is not the technology. It is the chasm between what AI can detect and what medicine can treat. Researchers call this the diagnosis gap. AI systems can now identify Alzheimer's pathology in patients showing 0 cognitive symptoms. Blood tests measuring phosphorylated tau 217 can flag preclinical Alzheimer's with 94% accuracy in completely asymptomatic individuals. The science is robust. The problem is that identifying disease early only helps if early intervention changes outcomes. For brain cancer, earlier detection generally improves survival. Fast glioma, developed by the University of Michigan and UCSF, detects residual cancerous brain tissue during surgery in 10 seconds with 92% accuracy, catching dangerous tumor fragments that traditional methods miss 24% of the time. But for Alzheimer's disease, the calculus is more complicated. A systematic analysis published in Diagnostics concluded that predictive Alzheimer's disease testing has been considered unethical because no effective prevention and disease-modifying treatment is available. While anti-amyloid treatments like lecanemab exist in the United States, their real-world effectiveness remains debated. The European Medicines Agency rejected lecanemab entirely. This creates an agonizing scenario. I can tell a healthy 55-year-old that they will likely develop dementia in 8 years, but medicine cannot necessarily stop it. The question becomes, do you want to know? The human cost of this knowledge gap extends beyond the patients themselves. Research on false positives in other screening contexts provides a warning. A Danish cohort study published in the Annals of Family Medicine found that 3 years after being declared cancer-free, women who had received false positive mammography results still reported greater negative psychosocial consequences than women with normal findings. 6 months after a false alarm, their changes in existential values and inner calmness were as severe as those experienced by women diagnosed with actual cancer. Now translate this to brain diagnostics. AI-enhanced screening of asymptomatic adults reveals that 5.8 to 9.5% have incidental findings, mostly meningiomas and aneurysms. For every 37 healthy people scanned, AI finds 1 brain abnormality. Most are clinically insignificant, but the anxiety is not. Incidental low-grade gliomas, found in 0.05 to 0.2% of the general population, grow at an average of 3.5 millimeters per year. They may take 2 to 10 years to undergo malignant transformation. Do you operate now and risk surgical complications? Do you wait and risk missing the window? The patient lives in limbo, neither sick nor well, watching and waiting. Dr. Lana Jovtis Ryerson, Director of Neuroimmunology at Jersey Shore University Medical Center, captured the challenge when she said that across the neurology field, we recognize that it is important to recognize disease processes early, as it gives us the best chance to treat effectively and prevent worsening. Yet, too often, we see delays in diagnosis due to lack of biomarkers and inconsistent recognition of risk factors. The technology gives us knowledge. It does not give us wisdom about what to do with it. The medical industry has responded with both enthusiasm and caution. Darmion's BrainIAC became the first FDA-cleared prognostic test for predicting progression from mild cognitive impairment to Alzheimer's dementia, receiving de novo authorization in January 2024. Founded by Padide Vejdani in Berkeley, California, the platform launched nationwide in September 2024 with Medicare coverage, achieving 91% accuracy. Darmion is now conducting a 7-year FDA post-market surveillance study in partnership with major Alzheimer's research centers, including UC Davis and Washington University. Viz.ai has deployed 13 FDA-cleared neurocritical care algorithms in over 1,600 U.S. hospitals, covering roughly 2/3 of the American population. Stroke patients at Viz.ai-equipped hospitals receive treatment 66 minutes faster on average. The company is valued at $1.2 billion. Hyperfine built the first FDA-cleared portable brain MRI, costing approximately $50,000, 20 times cheaper than conventional machines. Their CARE PMR study demonstrated 100% sensitivity for detecting dangerous brain swelling in Alzheimer's patients on certain treatments. The Gates Foundation is backing expansion into low-resource settings globally. In the UK, all 107 NHS stroke centers now use AI tools for near-instant CT analysis. The government has invested over £16 million in AI-powered dementia diagnostics. Cognitivity Neurosciences has deployed its FDA-cleared CogniCA test, a 5-minute iPad-based cognitive assessment with 93% sensitivity through NHS trusts including North Staffordshire and Sunderland. The infrastructure is being built. The question is whether society is ready for what it reveals. So here is the bottom line for 2026. Artificial intelligence did not replace doctors. It replaced the comfortable assumption that a clean bill of health actually meant you were healthy. The scan you received last year might contain evidence of disease that will not manifest for another decade. I can read that evidence now. The institutions winning this transition are those treating AI as a collaborator, not a replacement. Dr. Curtis Langlotz at Stanford offered the defining framework. AI will not replace radiologists, but radiologists who use AI will replace those who do not. The most important finding across this research is not any single accuracy number. It is that AI is transforming brain diagnosis from reactive to predictive. Medicine has never faced this question at scale. What do you owe someone whose disease you can see but cannot yet stop? The pendulum will eventually find balance. Treatments will catch up to diagnostics. Ethical frameworks will mature. Insurance and legal systems will adapt. But right now, we are living in the gap, the moment when technology can reveal futures that medicine cannot yet change. The scan already held the answer. We just could not read it yet. Now we can. And that changes everything. Want more videos exploring how AI is transforming medicine and careers? Subscribe for weekly deep dives and share your thoughts in the comments below.